Alrighty. Hello, everyone, and thank you for joining us for the Department of Public Health Cancer Section, Project ECHO. And we are honored that you would make the time to join us today to hear us speak on a second part of prostate cancer. And today we are honored to have our Dr. Eric Whalen. I'm probably pronouncing that wrong. I was just told that.
Wallen.
Wallen, thank you, sir. My
But
short-term
I'll
memory.
answer to anything really. It's
No,
fine.
don't you dare. Don't you dare. John, to pull up your bio, doing two things at one time has never been my skill set, but I will get there. So we are almost there. Awesome. I'm there.
And Sonia, if we'll wait a few minutes, so we can make sure more of the attendees are arriving. At the moment, we're just sitting with a couple of them.
I'm fine with that, Jordan. Thank you.
Also, Sonia, I will admit that I'm not a fan of the long bio. I'm happy to introduce myself. It's up to you.
Okay. Vanita had some information for me. She highlighted it, but I would be glad for you to introduce yourself and then go into your presentation as you see. So thank you again for that.
Sure. I guess just tell me when I should start.
Okay, good deal. We'll give it just a couple more minutes. Let's say 12:07. And let me ask you, are you including like a patient case study as part of your presentation today?
I will pause and talk about some specific patient scenarios that I have seen as I'm going through some of these slides. So I think the answer to your question is no, because it's not like a formal case study, but I'm happy to be asked about a specific situation if people would like to. And I did get good feedback when I presented it last week to the CMO group about some specific things that I think warrant some discussion. I didn't change the slides, but I will mention that it's related to getting additional testing before referral to urology. And I think it's actually a very important practical matter for this group.
That sounds perfect. Glenn, if you would go ahead and put in the chat for us when you have a moment the evaluation link. And thank you, ma'am. And definitely before the session ends, I will try to remind the participants of that at least twice. So, okay, it is 12:07. Jordan, let's go ahead and get started. All right, everyone, again, thank you for joining the session today. And today we are honored to have Dr. Wallen speak to us on prostate cancer. Doctor, if you would introduce yourself and then proceed into your presentation.
Thanks, Anya. I have been at MUSC for a year now in the chair position, and it's been a real thrill and a large challenge being here in that role. Prior to that, I was at University of North Carolina in Chapel Hill for about 20 years, and so had deep roots there, and including my passion project was working with communities, patients, particularly Black patients, around the state of North Carolina to improve awareness and screening for prostate cancer. My clinical interest is in prostate cancer, kidney cancer, bladder cancer, a little bit of testis cancer, but I also practice urology in its full breadth, stones, et cetera, like any urologist in my department. But really, what really gets me going is talking about rurality and prostate cancer screening. I will say that I was really kind of staggered when I moved here and started seeing patients even though it was only one state away, about how much poorer prostate cancer screening is here in South Carolina. So we have a big job in front of us. But I was also really gratified to see, first through Marvella, then through this group, how much interest there is in changing that. So I'm just really excited to be here. I'm happy to entertain any questions or scenarios anybody would like to pose as I talk about what I would call part 2, which is practical aspects of the prostate cancer screening algorithm. Let's see. Okay, in advance. So today I'll review the guidelines very briefly. I'll discuss what I think is more practical to use, which is age-appropriate screening recommendations. Then talk a little bit about things I discuss or primary care doctors could discuss if they wanted to or had time with patients, and how to handle positive screening results, and then also to share some online resources that may be helpful for patients or providers in this complex area to help guide you and them. So the current guidelines, as we all have learned, are quite mixed. These are in alphabetical order, not in order of controversy. The ACS says shared decision-making if the patient is average risk. A high-risk patient is that with a first-degree relative or African-American, and age 40 for the highest risk patient, which is more than one first-degree relative and or African-American. The AUA, again, offer and share decision-making between 50 and 69 and screening for every 2 to 4 years. Younger for patients who are Black, sorry, that should say 40 to 45, or for patients who have known germline mutations or family history. So I am starting to see patients who test BRCA positive because they have a parent, a mother usually is diagnosed with breast cancer and gets genetic testing, and they get sent to me in their 40s for prostate cancer screening because of the higher risk of prostate cancer in BRCA2 positive patients. And we also say through the AUA, you can offer all patients a baseline PSA at age 45 to 50, because we know that if the PSA is below 1 at the age of or before of 50, that it's extraordinarily unlikely that they will ever develop a lethal prostate cancer. NCCN guidelines, a little bit more broad, and USPSTF, shared decision-making for men 55 to 69. And the letters there are the level of recommendation. So it's a C-level recommendation, which is not a strong endorsement. D is even worse, which is probably not to do it. That's for men greater than the age of 70. What I think is real straightforward, or at least something that can be shown on one slide that will work, is this: age-specific ranges for PSAs. What we really need to undo is this report that comes from any lab, almost every lab, that does not include age-specific recommendations and has this cutoff of 4. We are far beyond that, and we should not use that as a cutoff, because a PSA of 3.5 in a man in his 40s is quite concerning, regardless of ethnicity. For a man who is 70, 3.5 or 4.5 is fine. And we don't need to see that patient, but if we do, we'll have a conversation anyway and assess their risk. So this, I think, actually works because it's simpler and captures pretty much everything that we've been talking about previously with all of you. So there are a number of things that we think matter in terms of minimizing artifactual elevation of PSA. If a primary care doctor, as is often the case, does not have time to do this, we'll do it when we see the patient. So I'm not asking anybody to do this before referring, but if you have the time, yes, we ask about BRCA risk, so that's prostate, breast, pancreatic, and ovarian cancer. We ask about pelvic pain or perineal pain or discomfort. Some men will say they have a sense of sitting on a golf ball, especially during a long car drive, or testicular pain. That is indicative of inflammation, and we usually will test the urine and treat with antibiotics only if positive, or even treat with anti-inflammatories if a culture is negative. because inflammation can elevate the PSA. Recent instrumentation, as we call it, a catheter, a scope, a colonoscopy, or an infection, we generally going to recommend waiting a couple of weeks before getting that PSA done because it can, again, be artifactually elevated. I have had many cases of cyclists, motorcyclists, farmers who sit on a tractor for a long time, or patients who ejaculated in the prior 48 hours with an artifactually elevated PSA. So I ask them these questions and I repeat the PSA after 48 hours minimum abstinence. Half-life of PSA in the blood is 2.2 days. And for whatever reason, the prostate is stimulated to release more PSA into the bloodstream with those various activities. So PSA, a little tricky in that way, and we'll always repeat the PSA. In fact, our board recommends that we always repeat it. One thing that I do think is very important for primary care doctors to know that if a patient is taking finasteride or dutasteride, it'll have the PSA. So in order for us to screen appropriately, we must double the result and then apply the age-specific range. So whether it's a low dose for hair loss or the regular dose for urinary symptoms, it will have the PSA. So we always double that, then we decide if it's elevated or not. When prior values are available, that's really helpful. I have seen a number of patients who have a PSA of 8, and they're concerned and I'm concerned, but I look back in their records and I'm able to find that it was 8 3 years before that and 7 5 years before that. That is not a concerning PSA trend. That's not the way the prostate cancer behaves. That's most likely a man with a really big prostate. Think about the prostate as a PSA factory. The bigger the factory, the prostates can get big, maybe not this big, but, prostate that is small makes a certain amount of PSA because it's not a cancer-specific test. But the factory is larger, big prostate, the PSA will be higher. So we think about that when we're talking to the patients. We ask about urinary symptoms because that might be a clue that there is prostate enlargement. Like I said, we always repeat the PSA. And if people are still doing digital rectal exams, it's okay to draw that. It doesn't really affect the PSA. So we're pretty solidly in the gray area in this era of PSA screening. But I still think that with our support, we can handle all of the nuances with this. I think that patients should be referred to urology whenever there's any question about a screening result. I think it's pretty important coming into the door or at the time of referral that both parties, the PCP and the urologist, demystify this a little bit. And I'll show you some online resources that can help with that. One thing that will keep men out of the clinics is the fear of a digital rectal exam. So they should know that we're not going to do that. That would be really unlikely. One exception would be a man who's 80 who gets a PSA. I might do a digital rectal exam because I'm thinking really hard about not proceeding further with an 80-year-old man with a PSA of 7. But if I feel a large cancerous nodule, I will proceed with the evaluation in a healthy 80-year-old man. As I said, I always want to know prior PSA values. They're available. Use the age-specific range. I referred everybody last week to this group that has created this comprehensive list of urologists. It's still in evolution, but what we would like to see is that patients can get a urology appointment without traveling for hours and hours. The truth is that we have a lot of urologists around the state who would be willing to engage with this group. So I feel very optimistic about this, and we'll get them all on board so that they can expect that if screening increases, that they may get more elevated PSA patients. Okay, so the patient gets to us. I will ask the questions that I covered previously. Excuse me. And then we engage in what's called shared decision-making about the next steps. Sometimes we do secondary screening tests. 4K is a blood test. ExoDx is a urine test. And this can help refine screening. We'll often order an MRI if we have a high degree of concern in a patient about going down the path, if you will, towards biopsy and possible diagnosis of prostate cancer. I will not order an MRI if the patient has a PSA of 50 or 80, which I'm seeing distressingly frequently, because it's unlikely that's going to help me locate something that is a small and subtle lesion. That patient has prostate cancer, and we just proceed as quickly as possible to biopsy. We will sometimes thereafter use a PSA for staging purpose. MRI for staging purposes after the diagnosis. But the key thing is to get the patient a biopsy as soon as possible when the PSA is very high. This is a tool that I think is really great for shared decision making. It could be used in the PCP setting, or we use it to help frame the discussion with the patient. If you can see, it's relatively small. We enter the race, the age, the PSA, the DRE, which is, you're allowed to skip that, prior biopsy history and family history. And that really predicts what the patient's risk is of having a high-grade prostate cancer. And I'll print this and show it to the patient. This usually elicits a sigh of relief when I do this, because I think many men walking into the clinic think they have prostate cancer and that it's going to kill them. But framing the discussion this way before discussing next steps is often very helpful. So in this particular illustration, this PSA is 4.2 in a 55-year-old man who is Asian. Okay. There's a 2 in 3 chance that the biopsy is negative. There's a 21% chance that there's a low-grade cancer. And I tell the patients, those are cancers we wish we never identified, wish we never knew about it. Sometimes I even wish it wasn't called cancer, but that's a debate for another day. There's a 12% chance of a high-grade cancer, and I flip that and tell the patient there's an 88% chance that you're good and a 12% chance that maybe you're not good. And that my job as a urologist is to make sure that we understand whether or not you're one of those 12 patients or only 1 in 9. In that context, patients are ready to have that discussion about taking next steps. Then I add, we can refine your risk by doing an MRI. We can refine your risk by doing one of the secondary screening tests like 4K or ExoDx. I'm doing essentially only ExoDx. Happy to discuss why later on if we have time, because that will change the number of patients at risk on this chart. So this chart is based on large screening trials, both in the United States and in Europe over the past 30 years, that are very informative for these discussions. So I think this is super helpful. As always, we debate with patients, we inform them, we say, you know, we're thinking about benefits versus harms, and we're always going to keep that in mind, and we always can step off this path towards prostate cancer treatment if at any point you, the patient, feels like the harms outweigh the benefits. But let's find out what is, if any, the status of your prostate cancer. To review, reducing harms of screening from our prior talk, we do the MRI. If the MRI does not show concerning lesions, we'll not biopsy a patient. So a number of patients will fall out that way, which is a good thing. We do biopsies in a different way that decreases infection rates. So again, reducing harm. For treatment, we have 2 things that I think matter a lot these days. Active surveillance, first of all, is the greatest advance in our field in the last 25 years and is being adopted more and more for those low-risk patients. Those are the people that are in the light blue here. So over the years, more and more urologists are getting on board with observation and active surveillance for these patients rather than radical treatment with all of its risk. And then most recently, there is the advent of focal therapies, which treat instead of the entire prostate, which is standard of care with radiation or surgery, treating only a lesion, if there is a single lesion in the prostate, and by virtue of treating only one part of the prostate, side effect risk is much, much lower. There's clinical trials for this, but there's also FDA-approved modalities, including something called NanoKnife or IRE, which stands for irreversible electroporation, that we offer here. Other areas around the state, other practices offer something called HIFU, which is high intensity focused ultrasound. Again, just treating the lesion. So here's some resources that I think are really helpful. These are not active links, but I think can be searched for those who are interested. CDC has some really great stuff for this patient facing. This is since every talk these days has something about artificial intelligence, you can have a conversation with Nathan about prostate cancer screening as a patient. We can show this in the clinic to people. The single best website that I know about and resource online for every phase from screening to clinical trials to chemotherapy is called Prostate Health Education Network. It's a national network and it's phenomenal. They're a great partner. They partnered with me at all of my events in North Carolina. And there's this Dr. PSA piece there to discuss with Black men prostate cancer screening. I think it's a really great place to point patients. In fact, it has such great discussions of treatment options that regardless of ethnicity, I send patients here to learn more about their treatment options because it's such a great resource. But it is geared and directed towards Black men. Just for review in this talk, these are the American Cancer Society recommendations. I think this is really the counterbalance to the USPSTF recommendations. I think we should be thinking about cancer focus rather than epidemiology when we talk to our individual patients. That's my opinion. Happy to debate that. Then here's a video from a music group, which is in Michigan. It's a statewide collaborative, and it has a description of what is a transperineal biopsy. That's that new technique that lowers infection rates for information, just to demystify the process for patients. I will stop there and stop sharing for questions and feedback.
Allie, you have a question? Go ahead and ask, please.
Hey, yes. Thanks again, Dr. Wallen. Great presentation. My question is going back kind of towards the beginning of your presentation. You were kind of talking about some of the things that can affect the PSA and the screening, some of the things that people might do before that screening. And I was curious if maybe that's like a lack of having a conversation with the patient leading up to the screening. Like, are they given anything, print out an email, some kind of reminder to let them know, hey, here's some activities to not participate in leading up to your screening. And maybe that's, something that we could potentially look further into is more of like a patient reminder. Here's what not to do before your screening.
Yeah, you raise a really important point, and one where I don't get to participate in that because my patients are referral patients. So how to address this? We created like a one-pager for patients, like a flyer almost for our community events to pass out, even when we weren't doing screenings. So, it would be like a family health event where we would have a table and we would have this one-pager that said, you should consider PSA screening. These are the things to think about before getting screened. Getting that information to patients would certainly enrich the experience or at least the accuracy of screening events. But what's the word? Pragmatically, how to do that is a challenge. Another question before we move on is, I was asked by one of the CMOs about getting an MRI prior to referral to the urologist. Now, I think that's very efficient and very effective, but I don't think a requirement for that is fair to the primary care doctor or necessarily to the patient. I don't want to put up barriers to prostate cancer screening and getting people to that discussion about taking the next step for MRI or even biopsy. but some urology practices have, in which case it's difficult for patients. And I'm not a fan of that as a barrier. And we don't have MRI machines all over the state that are readily accessible either.
That's a good point. Thank you.
Thank you for that question, Hallie. Vanita, you have a question?
Yeah, just because there's a lot of people here working in public health or with, insurance companies or with other organizations. I was wondering if you had suggestions, maybe not off the top of your head, but even if you could tell us later, like what are little p policy changes that would make the referrals process more efficient? For example, would it be do you know whether genetic testing is covered and whether that's a barrier for you when you see patients, especially when you consider rural areas? Like what kinds of little p policy focus areas would be helpful to the realm of prostate cancer being caught early and treated?
Yeah, Benita, that's a great question. I think, first of all, I'll say that I'm open to all, but I will say that an observation that I had made in North Carolina is in some of the clinics that were, public clinics for disadvantaged patients, they had automatically built into their EMR prostate cancer screening flags, just like colonoscopy screening flags and mammography flags. And I don't think most EMRs have that. I think moving in that direction as, I guess, a little p policy change would be very helpful when the primary care doctors are seeing patients and there's these lists come up of things that are needed at that age for that patient based on their ethnicity. As far as genetic testing, it has not been a barrier in South Carolina. And I am not sure that I can confirm why that is the case. I just think it is more widely accepted when justified in the clinic note, in the request that we make. So primary, first degree relative, for example, 2 first degree relatives. We have a very efficient genetic screening program here, thanks to a generous donor who set it up and helps us employ a PA who talks to patients on the phone, who sends them kits in the mail, who they can send back in the mail. It makes it very straightforward. And then if there's a positive result, they go for a formal genetic counselor appointment. But it has not been a barrier at all. I think sometimes the biggest barrier is patient awareness.
Okay, thank you very much. This is really helpful insight. And these are actually actionable things as well. So I appreciate it.
Of course.
Okay, I'm not seeing any questions in the chat. Let me think.
Oh, Marvella's here. Marvella, as always, glad to have you here and tell us your comments.
Thank you so much. This was a great presentation as always. I really appreciated the graphic that you showed that showed the really low, I guess, odds that a particular man would have a screening result that would indicate potential presence of prostate cancer. So that was really powerful. And I think that, communicating that to men in the community could really help to increase screening rates. That was very powerful.
Yeah, this website, do you see this? I think it's...
oh, yes, thank you.
I think it's great. I think exactly 0% of men come in with this knowledge. And that whether they get it at their screening discussion or after referral, it's really helpful in addressing the fear that patients have.
Yes, I've never seen this before, and it's just so powerful. I've seen something like this for lung cancer screening, but this is great. Thank you.